everyone. I'm Dawn Baumgardner, the Executive Director of the Diamond Blackfan Anemia Foundation. If any of you know me, you know that I am extremely camera shy, but I guess quarantine and a global pandemic kind of bring out the best of us and make us make changes. And I just wanted to connect with everyone and to let you know that we are here for you, that we are privileged to have Dr. Adrianna Vlachos here with us to answer many of the questions that we've all been asking. So on a personal note, thank you all for reaching out, for your emails, for your phone calls. Please know that I'm here for you. You are welcome to call at any time. And thank you for making me a part of your family. Sharing your stories with us, sharing your children with us, it truly means so much to me. So thank you so much for being here and for being such a huge part of my life. I'd like to introduce to you my beautiful daughter-in-law, Melissa. Melissa and my son Kyle have been instrumental in bringing this all together and making the live stream possible. During the session, I will be asking Dr. Vlachos the most common general questions that we have received from all of you. Please understand that it's not fair to Dr. Vlachos or for the viewers to ask questions that are specific to your patient. Without knowing your child's or your history, Dr. Vlachos cannot answer those questions. And also know that Melissa and Kyle will be monitoring the Facebook and the YouTube messages as they're coming in. We may not get a chance to address all of them, but they will be reviewed. It is also my privilege to introduce to you Dr. Adrianna Vlachos. Dr. Vlachos is from Cohen's Children's Medical Center and the Feinstein Institute of Medical Research. She joins us today in her capacity as the director of the Diamond Blackfan Anemia Registry. Dr. Vlachos lives and works in New York City, so you can imagine the impact that this has had on her personal and her professional life. So we are so grateful for her expertise and for her commitment to the DBA community. Before I begin with the questions, I'd like to provide a little bit of clarification between the Diamond Blackfan Anemia Registry and the Diamond Blackfan Anemia Foundation. The Diamond Blackfan Anemia Foundation is a 501c3 not-for-profit organization. We have been in existence since 1994. Because of your support, we provide support for research patients and families. We have funded several worldwide research projects. We also host the family meeting at Camp Sunshine and the premier scientific symposium, the Diamond Blackfan Anemia International Collaboration Conference. So thank you all for your continued support. The Diamond Blackfan Anemia Registry, the DBAR, is a medical compilation of all of the data that we need to make statistics meaningful. So questions that you ask, questions that researchers ask, how many people go into remission, how many people respond to steroids, all of that is because of the information that is given to the DBAR. Dr. Vlachos, along with Dr. Jeff Lipton, Eva, Miriam, and Maria are the DBAR team, and they are there to get your information, to make it make sense to everybody. So I really encourage everyone to support both the foundation and the DBAR. You can find us, dbafoundation.org and dbar.org. We are not allowed to share information because of HIPAA regulations. Dr. Vlachos certainly can't tell me about patients. So please make sure that you know the difference between the two of us. Reach out to either one of us if you have any questions. For our question and answer period, Melissa has organized our questions, and we're going to be covering them in 6 main topics. The 6 topics are: who is at higher risk, precautions, questions from transfused patients, questions from steroid-dependent patients, questions from transplant patients in remission, and then finally COVID treatments and vaccines. So we will get started with our first questions. Dr. Vlachos, you are the star of the show. Go ahead and take it away if you'd like to say anything first before the questions start.
Sure. Thank you, everybody. Thank you for inviting me today to do this. I really appreciate it. I thank the work that Melissa and Kyle have done in the background, and for Dawn for actually being on screen, because we all know how much she doesn't like her picture taken. Hopefully, what we're planning to do is I'll be giving general knowledge about the novel coronavirus today, and we're going to obviously called COVID-19. I am an expert in bone marrow failure syndromes and in particular Diamond Blackfan anemia, but I'm in no way a COVID-19 expert. So I've gathered information today from as many sources as I could for this interview, and I'll be trying as best as I can to answer the questions. If you have any questions about possible symptoms of coronavirus infection that you or your child are experiencing, please call your or your child's physician. Okay, so COVID-19 is caused by a new coronavirus. Coronaviruses are a large family of viruses that are very common in people and are common in many different species of animals. The typical normal coronavirus causes the common cold. So we hear that a lot, and we have many, and children have coronaviruses all the time, and therefore parents get coronavirus all the time. This one, however, is a novel one, and rarely the animal coronaviruses will jump from the animal and infect people. And that's then what causes the spread in people. It's the same virus. This is a very similar to the virus that caused Middle East respiratory syndrome called MERS, and the severe acute respiratory syndrome called SARS. So now we have this new virus. This is actually it's called SARS-CoV-2 because it's the second one that's from the SARS family, in the coronavirus family. And obviously we are calling it COVID for coronavirus virus disease. That's what COVID stands for. And what we can say today is that there's many reported illnesses that have ranged from very mild symptoms to no symptoms at all, to very severe illness, and unfortunately to many deaths throughout the world and obviously throughout the country for these confirmed cases. Symptoms can occur 2 to 14 days after exposure. Usually they present with cough, with fever, with shortness of breath, with severe muscle aches. Some people, again, have no symptoms at all. Some have mild, and some have such worsening symptoms that they require hospitalization and potentially intubation, which is being put on a ventilator. So that's kind of the brief version of COVID, very brief version. We'll talk more specifically as we go through the questions. So I think that's all I have to say, Dawn, for now. And we're going to, I guess, go through the questions that Melissa and everybody have put together.
Right. So topic one, and just so you know, these questions came from our families, and we received hundreds of them. So we kind of condensed them. And we think we got almost everybody's questions answered except for those patient-specific questions. So topic one is questions regarding who is considered high risk. Which DBA patients are considered to be at a higher risk than the general public when it comes to contracting and succumbing to COVID-19? All of them?
So this is obviously a very complex question. In the general population, what we know so far is that older age, obesity, high blood pressure, diabetes, cardiac disease have been risk factors for getting very sick with the novel coronavirus. There's some newer data saying that African Americans seem to be worse than others. That data is still very new, and that'll hopefully be clarified as time goes on. We don't have any data, zero, obviously, for DBA patients. So with regard to contracting the virus, specifically for DBA, those patients on high-dose steroid trials and patients with known immune suppression can be at higher risk. We theorize that patients with high iron burden, with cardiac disease from iron overload, those with diabetes from iron overload, and our older DBA patients may also be at higher risk of COVID complications.
Okay. Is a person on low-dose prednisone with normal white blood count at greater risk than a person without DBA? Is there a maintenance dose of steroids, which they are no longer considered immune suppressed?
So that's a great question. So what we consider in the DBAR and all the researchers throughout the world that we work with for DBA, less than 0.5 milligrams per kilo per day or 1 milligram per kilo every other day of prednisone is not considered immunosuppressed. And in fact, at these doses, patients can receive live virus vaccines without any increased risk.
Okay. If a person is in remission, would they be considered at higher risk because they have an underlying condition?
So in general, DBA patients are not immune suppressed. So most patients are considered regular risk. However, again, it depends on the dose of steroids if the patient is steroid dependent. It depends on the severity of the iron overload if the patient is transfusion dependent, and the patient's overall health, whether the patient has endocrine problems like diabetes or thyroid issues or cardiac issues. So each patient has their own individual risk profile, and that has to be considered on an individual basis.
Does being iron overloaded or chelating put a patient at higher risk?
Chelation does not appear to put a patient at any risk for viral infection. Iron overload, unfortunately, can put you at risk for certain bacterial infection, and of course can put you at higher risk for endocrine disorders like diabetes, low thyroid hormone, a poor stress response by having a lower adrenal response, heart failure, cardiac or heart arrhythmias. So again, the individual risk profile has to be considered. Really depends on how iron overloaded someone is.
I'm going to throw this one out at you, Dr. Vlachos. A question that I had just received was because of some of the congenital anomalies with the cardiac or with the kidney congenital anomalies. Would that put someone at a higher risk?
If the heart is working okay and the kidneys are working okay and the functions are normal, then that would not put you at higher risk. If you have a cardiac defect that causes an arrhythmia, that puts you at a higher risk.
Okay. Many DBA patients never had T-cell or IgG studies done. If a patient has not had those done, should we just assume that they are immune compromised just to be safe?
Again, DBA is not in general an immune suppressive disease. So patients with certain mutations for RPL35A, for some others, they may have immune suppression. Usually those patients have a severe history of infections that have to be considered when we're putting together the risk profile. And for those patients, we have asked for T-cell numbers and IgG studies to be done. If the patient has been fine, doesn't have frequent infections, et cetera, then we don't think that that should be an issue. Patients that are receiving immunoglobulin therapy, IVIG, because they already have an underlying immunodeficiency, those patients are probably not yet, but in the near future will be protected because the IVIG that we're getting from patients that already have antibodies against COVID will probably protect them. If the patient's on low-dose steroids, they're generally not immune suppressed, nor if they're on transfusions routinely.
Okay. All right, we're going to move on to topic 2, which is precautions. Are there any special precautions in addition to the general guidelines of staying home, good hand hygiene, and disinfecting items that we should be taking to keep our DBA kids safe?
So it's kind of what I'm doing. Masks and gloves should be used when we're walking inside and outside of the hospital for clinic visits to receive transfusions for regular blood counts. I think that's standard for everybody, at least here in New York, grocery stores, et cetera. Everybody's wearing masks and gloves now. I do want to just spend a minute talking about the low white blood cell counts and low neutrophil counts, because some patients with DBA do have that. And again, we already just mentioned before about certain DBA patients do have a true immune deficiency. But the patients with neutropenia are not immune deficient. Neutropenia does not define immune deficiency. When patients are neutropenic, that means that they can't fight a bacterial infection because the white count and the neutrophil count are low. But usually in our DBA patients, when they get a bacterial infection, their white count and their neutrophil count tends to go up. So they're functionally able to fight that bacteria. So even though they might stay at their steady state at a low number, they can actually bounce up when they need to for a bacterial infection. So, and that doesn't make you, like I said, immune compromised because your immune system comes from your lymphocytes. So our body uses our lymphocytes to fight viruses. So the neutropenia in some patients won't make them susceptible to COVID. If they have low lymphocyte counts, that would. And most of our patients don't have that. To date, and I looked this up for our statistics as well as in general, there have not been secondary bacterial infections in patients with neutropenia and COVID-19 infections. And we've actually had quite a few cancer patients that have come into our hospital that are neutropenic because they've gotten their chemotherapy and they also have COVID disease. And they have seemed to tolerate the COVID, especially in the children. They seem to be tolerating it pretty well and able to be get through their COVID-19 and go home without much of a problem. So they seem to be handling it okay. We do have a few that have not, but that's because they have cancer and they have many other issues, obviously, as well. But in general, we've done pretty well. And the same thing on the adult side. We've been stopping the antibacterials when they come in because they don't seem to need that.
Okay. My question is about extra precautions that post-transplant patients should take. Even though the transplant was over a year ago, the DBA patient's immune system is still not 100%. What would you recommend for patients in this situation?
Same thing. Good hand hygiene, stay home, protections when you go into the hospital, continue the recommendations from the doctors regarding if they're getting IVIG, which many patients after transplant do get. That gives them passive immunity to many viruses. And as the population gets more and more COVID antibodies, they will have that immunity to COVID as well.
Okay. If a patient has a port and was told to go to the ER with a fever of 100.5 before the coronavirus outbreak, should we still do that if there are no other symptoms? I don't want to risk going to the ER.
I know you don't want to risk it, but you absolutely have to go. You can't take any chances with a fever and a port or a Broviac catheter. It is a foreign body. It can get bacterial infections. It's a scary time, we know that, but you don't want to have a severe complication or even death from a bacterial infection that could easily be treated. So unfortunately, you do still have to go in. Emergency departments are essential. They're still caring for the non-COVID emergencies. We still have to go in there. Contact your physician. When that happens, they'll tell you what's the best way to receive the urgent care. There are places where the ERs are separated. There's a COVID section and a non-COVID section, or urgent care places where they're only doing COVID patients and places where they're not doing any COVID patients, meaning that they're not accepting patients with coughs and fevers and those kind of things. So call your provider, let them know, and they'll make the decision. But you absolutely still have to have that antibiotic given.
I do have a question that came through. I know we're going to talk about steroid-dependent patients in a little bit, but we do have a question regarding steroid-dependent DBA patients developing a fever. And they ask if a steroid boost is okay, if they are a possible COVID case, just kind of. And like I said, I know we're going into it with the steroid topic in a bit, but just kind of fever and steroid use.
So we're going to address that, I think, in a little bit, Dawn. So do you want to wait, or do you want me to answer it here?
I think Melissa is saying, I don't know if our question specifically asks about a fever in steroid kids. I mean, I think our next question, let's see if we wrap it together. Okay. Let me read the next question, because that is about fever too, and it might be maybe if they're on steroids. Okay. So if a patient does not have a port, how high of a fever would warrant a call to the doctor or the ER visit?
So if they're on steroids, and again, for those patients with the known immunodeficiency part, in those patients, we usually have them call if they have a fever of 100.4 Fahrenheit or 38 Celsius. Please continue to call the doctor's office as before. Whatever your doctor's rules are, that's when you call. It's easier to make a phone call. That's easy. Your provider then will decide on whether you go to the emergency room or some other urgent visit. For transfused patients without a port, and those that don't have any documented immune deficiency, we usually do 101.4. But again, if it's different for your facility, you do it based on your facility. Just follow the guidelines that you've already had. But either way, a CBC may be necessary for any fever, since we don't know how COVID will affect the patients with DBA on steroids or on transfusions, or even those in remission. Will it make their hemoglobin lower than usual, and they may need either a transfusion or a bump, et cetera. So those are things that we're going to hopefully try to figure out as we hopefully document which patients, if there's any patients with DBA that happen to have COVID-19 as well. And we'll talk a little bit about that later. We're trying to put a questionnaire together and have people call us if they have a family member, a DBA patient or a family member with DBA that has fever and has COVID. That has COVID, not fever. In terms of the other question, you want to wait, Dawn? Or you want me to?
Either way.
Say it again?
If you do it now, if you want to. If we do it again, we will skip over it.
Okay. So with regards to boosting, we're actually using steroids as an anti-inflammatory for some severe patients with COVID disease. So there's absolutely no reason that we think that steroids would be contraindicated in someone like this. And if they have a high fever with COVID, they should go ahead and get their stress dose of steroids. It's very vital. If not, and those patients have adrenal insufficiency, that's going to be a problem because then they'll have low blood pressures and other problems that they won't be able to handle when they get a high fever. So as far as we know, there's no danger to giving the stress doses. We've been giving the stress doses to our patients that are showing up, that are on leukemia treatment, for example, and that are steroids. They're all getting stress dose when they come in with or without COVID, because when you first walk in, if you've been on steroids, you get the stress dose. And then we figure out whether you have COVID, 24 hours, 8 hours later, 24 hours later, 2 days later. So you have to get your stress dose. We don't want anything to happen to anyone because they didn't get the stress dose of steroids.
Okay, thank you. What additional precautions should we take when going to the clinic or the hospital to get our transfusions?
So again, for us, we've been wearing masks and gloves in the hospital to walk in the door. Obviously, you're going to be touching elevator buttons. You're going to be handling doorknobs. So everybody gets, we've been wearing, everybody's been wearing gloves in terms of the patients. And then when they sit in their bay that they're going to get their transfusion on, they can take the gloves off and do their phone and do whatever they're going to do for the next 2, 3, 4 hours. But that's the biggest precaution that we've done. Unfortunately, most of the patients have to continue wearing the mask, which is uncomfortable for hours, but that's what we're all doing. I'm going to reach over. Mine's right here. I'm quarantined in my children's bedroom that used to be their bedroom when they were little. That's why you have these pictures in the back. And when they walk in the door, I've been on service now for 2 weeks. I'm on quarantine for myself I was on for 2 weeks, so I've been in this room for 2 weeks, except when I go to work. And I will be going, I'm still on 2 weeks starting yesterday, since that was my last day on service. And they walk in the door and I put my mask on. I go downstairs, I put my mask on. I wash my hands 1,000 times. So that's the only way to do this. And we're all doing it just as much as you guys are.
I hear you. Okay, we're actually right into our next question. The CDC, NIH, and other organizations are now advising masks for all. Should we be wearing masks outside of the home, even if we are keeping our distance, for example, going for a walk?
So again, we need to follow whatever the CDC guidelines are. And I know that they've been changing, so it does get very confusing. Right now, we know that there's definitely people out there that are asymptomatic, that they may have had it already, or they're going to have it tomorrow in the pre-symptomatic stage. So they can be transmitting the virus to others before they're even showing symptoms. So the CDC right now is recommending that everyone wears some type of cloth face covering in public settings, despite the fact that they're still also recommending the 6 feet social distancing. So when you go to the grocery store, when you go to pharmacies, etc., wear something on your face. You don't have to go out and buy a surgical mask, and I know they're very hard to come by. Wrap a scarf around your face, put something around your face. Those things can be taken off and washed when you get home, but that's something that just somehow cover your face so we're not getting everything onto us when we're out and about. Obviously, still 6 feet social distancing despite the masks. Don't worry about N95s. When I go to the grocery store, I don't wear an N95. My N95 is at work. It's in my desk. We have bags for them that we keep them in. We put them on. And right now, we're only putting them on when we go onto a COVID floor, when we're going into a COVID room. On a regular floor, right now, we are not wearing our N95s all the time. We're wearing our surgical masks. So when you're going outside, putting a cloth or something over your face is important. And again, that may change. In New York, that's what we're doing. I don't know if they're doing that in Buffalo. I don't know if they're doing that in Kentucky. So listen to what's happening in your area and obviously follow that advice.
Okay. Would it be advisable for DBA patients or their family members to always wear a mask around other family members who they live with that must go to work, like you?
Like me. So again, I think it's easier for me to wear the mask than to make my whole family wear a mask, since I'm the one that's going out. So I wear the mask. I take precautions in my house. Right now, obviously, I'm separating myself from my husband and my children. I'm eating separately. They bring me lunch and dinner to my door over here, and I bring it inside and I eat it. I wear a mask while I'm walking around the house. And I try obviously not to touch as many things. And when I do, I take a napkin or something else so I'm not touching with my fingers, but I'm hoping not to put my hands on my face. So those are precautions that unfortunately we're going to have to do for a while.
Okay, a question just came in. If a patient is in a private room during a transfusion, do they need to wear a mask the whole time they're in a private room?
If they're by themselves, then no. The question is who's coming in. So when the other person comes in the room, they should put their mask on, even though hopefully the nurse has a mask on as well. So they can take it off to be comfortable in eating or whatever they're doing during the transfusion. That's fine.
I have heard not to give elderberry syrup, but it's okay to give extra vitamin D. Not to give Motrin, but it's okay to give Tylenol. Can you provide any advice on these products for DBA patients?
So these are a little bit difficult. So data on alternative treatments for COVID are totally lacking. So all of this has to be taken very cautiously. There's no scientific studies yet to support the use of any of these remedies in patients with DBA and in patients with COVID in general. So elderberry syrup it's a compound that's been around obviously for a long time. It's supposed to decrease the ability of the viruses to infect cells. Supposedly it's been reported to shorten the duration of symptoms of flu B, specifically flu B is the one paper that I could find, which is one of the causes of the common cold. And they're supposed to be involved in somewhat in the inflammatory response. And therefore, when I looked up some things, knowing that this question was coming and that there's been a lot of talk about elderberries, the nutritionists say, and this is all from that data, which is it's not strong scientific data, that there's, we know that there's an extra inflammatory response already to COVID-19. So therefore, the nutritionists are saying to hold the elderberry and don't give it at the site of an infection because it may make the inflammatory reaction even worse. So again, take that with a grain of salt. I'm not really sure what else to make of it. In terms of vitamin D, that's very, very important as part of our immune function. It's important for us for bone health, for brain health, and many, many of us are vitamin D deficient. All over the world, we put sunblock on to protect ourselves from skin cancer. Especially if you're fair skin like me, I always wear sunblock. I wear long sleeves. My vitamin D level's on the floor. I always have to take. I'm looking at Melissa, who's also very fair, and Dawn. We live up north where we get sun only for 2 months of the year. So we really are vitamin D deficient. So it's very important that we all should try to have normal vitamin D levels. And now we're actually, even in pediatrics, are checking people in kids and recommending gummies with vitamin D for kids. And they're increasing the vitamin Ds in regular multivitamins. So it's very good to have a normal vitamin D level, but again, too high can be toxic, and it's a fat soluble vitamin. So don't take too much. Be careful about extra, and especially about high dose vitamin Ds. In terms of Motrin and Tylenol, very difficult for us. Motrin, I shouldn't say Motrin, ibuprofen is what we've been using always. We use it in sickle cell patients, et cetera. We don't use it in cancer patients. We use acetaminophen, better known as Tylenol. In Switzerland, there was a letter published a while ago that some researchers postulated that there was a lot of patients in China that had high blood pressure and had diabetes, and they were also taking something called ACE inhibitors. That is a type of medication that is seen in blood pressure in blood pressure medicines. We use it as a blood pressure medicine. And when they looked at this more carefully, coronavirus apparently, how it targets the lung is by binding to the ACE receptor. So these ACE2 receptors, so they postulated that there were some studies about when people take ibuprofen, the ACE2 receptors are increased, and therefore it may increase the amount of coronavirus that actually gets onto that lung tissue, and therefore those patients might be worse. Again, this is all hypothetical. It was a theoretical discussion. There was no data. It was really just a hypothesis. However, the French picked it up. It started becoming a big warning about ibuprofen, and not for patients with a fever not to take it. So they encourage people to take acetaminophen instead. So, but again, acetaminophen, Tylenol, can cause severe liver failure, especially if you're taking it daily, and these patients are having fevers for 8, 9, 10 days. So you can start with acetaminophen. You can use ibuprofen if you need to, cautiously, obviously. Again, don't exceed the guidelines for either one for the actual package insert when you're taking these, because we are giving it for days and days and days because of this, prolonged fever. So be careful. So we really don't have good data. This is all theoretical. Unfortunately, it kind of caught on. We're using Tylenol, but yesterday when I had a patient with a very high fever getting a transfusion at the same time, I gave them Motrin. I gave them ibuprofen. So we do it cautiously and we watch. So there's nothing else to do but to be cautious.
Thank you. All right. Is it safe for our family to see other quarantined family members who are sheltering in places as well, but at a different house?
No. How can I say no? No. No one is truly quarantined. Someone from the house has to go out to the supermarket, to the pharmacy, to get gas in the car, to go to work.
To get a transfusion.
To get transfusions. We're not really quarantined. Therefore, if you get in touch with the other patient, with the other person in that house who says they're quarantined, but someone went to the supermarket, then you've expanded your 3 people, 4 people in the house to 7 people and 10 people in the house to 20 people. So please stay at your house. Use FaceTime, Google, Skype, whatever you want to use. Say hello, kiss them over the computer, but do not see them, please.
Okay, I'm going to know the answer to this one, but I'm going to go for it anyway. Is it safe for siblings to play outside with other kids if they maintain a safe distance from their friends, riding bikes, playing basketball, if it's the same few neighborhood kids who are also quarantined in their homes?
Basketball is a contact sport. You're touching the ball, you're bumping the kids. That's not staying far away. That's touching people. Again, now you spread out from your 2 people home to your 2 family member homes to now 5 homes around the neighborhood. Again, they're not quarantined. Quarantined is you're isolated, you're in the room, I get it, but you're not quarantined. Somebody's out there. There has to be somebody. Even if you're getting Peapod delivered to your house, somebody's coming there, they're delivering pizzas to your house, somebody's coming in contact with somebody else. Please stay by yourselves as much as you can. I know it's difficult, but honestly, I know that you're in other places all over the country. Right now, our institution, as of this morning, we're getting daily hits. We've had over 3,350 COVID positive patients in our Northwell system. Our hospital has a capacity for 560 or 580 adults. That's the adult size with a big hospital. We are up to 850. 550 of them are COVID patients. We had 60 patients admitted the other night, and 50 of them had to be intubated, adults. So please stay home. I know that everybody's city is different than ours. I get it. But if it comes, God forbid, it comes to your city, it is horrible. And we're exhausted. The patients are exhausted. Their parents are exhausted. I cannot tell you how serious this is. So please, I know it's hard, but you'll be able to say hello to everybody next Easter. They can say it on Easter Sunday on Zoom. You can do things on Zoom. Please stay away from everyone else as much as you can.
I do have a question that came through in relation to the socializing from DBA Canada. They wanted to know, bringing their dogs to the park to socialize. So say you go to, I know around here it would be like a Knox farm where you can allow the dogs to kind of run around in an area. Is there risk with the animals socializing with other animals and then coming to your home?
So they've said that there's a tiger in the zoo that has it, and there's some dog in China, supposedly they cultured it from his nose. I've walked with my husband around the block with our dog, and we are on opposite sides of the street, and the dogs cry to talk to each other, to go near each other, and we don't let them go near each other. We do not let the dog socialize at all, because then he's going to lick my child. I don't know. Right now we have not.
Okay.
hard for the dogs too.
It is. Well, that's what I was going to say. It's
It is.
people, dogs, whatever. We all need to just quarantine and stay
Yep.
home and love
Yep.
each other and get over it. Sorry, but that's how I feel. This is really life or death
It's not going to
situations.
be forever, everybody.
That's
It
right.
really is not. It's going to be, I mean, I don't know if it's going to be
Suck it
another
up.
month, another 3 months, whatever it is, but it's not going to be forever. We're going to be okay. And we can really talk to each other. We have Zoom now. Before we didn't have that. I mean, come on. Or Skype or whatever, Facebook Live, whatever we have.
Okay, last questions and precautions. As an essential worker, I must choose between my job and keeping my DBA children safe. Do you think it's possible to work with the public and still be able to hug your kids when you get home? Should I move out? Are doctors able to write a letter saying it's advisable for parents of high-risk children to stay home? Are there any laws that protect me as a worker if I refuse to work to keep other family members safe?
So essential workers are obviously at incremental risk because they're in the public all the time. If an essential worker means that you're working overtly with COVID positive patients, the way I have been, then that person should come home, which is what I do, shower immediately about entering the house, launder my clothes immediately. Connecting with your family is really up to your own comfort. Working in a hospital without direct contact with confirmed COVID patients is a little bit different. Again, bus drivers, supermarket cashiers, et cetera, are all considered essential workers. We can't go anywhere without them, but they also have to wear masks and gloves at work, shower when they get home, launder their clothes, and take precautions to be with their family the way they see fit, depending on what they think. I personally am quarantined in a room. I have not hugged my child or kissed them or my husband in 2 weeks because that's what I'm doing. It'll happen again in 2 more weeks. What am I going to do? It's what we have to do. With regards to writing letters, we have written letters for parents to stay home, for children who are immune suppressed that are actively undergoing chemotherapy, for patients of children with severe neutropenia, as we don't know how COVID will be in those patients. I've written letters for parents that have to go to work because they don't have protective equipment there. And so I've written specifically letters for protective equipment at their jobs. If they're in the public, so if you are a bus driver, you need to have a mask and gloves. And if not, then your company needs to do that. Otherwise, it isn't fair for you to go to work. They're not protecting you adequately. So you can ask if you're eligible for family medical leave, if that works for you. And obviously the doctors will help you write letters for that if that's the case. But that's a little bit, case by case.
I'm going to throw one more in about precautions. Do you have suggestions? I know we're reading like for cleaning supplies, alcohol, bleach. Is it anything that we shouldn't be using or anything special?
Luckily, it's a very sensitive virus, so everything works. You have to have at least 70% alcohol in the whatever hand sanitizer you're using, alcohol-based. So it should be alcohol-based, but chlorine, purifier, hand sanitizers, they all work. It's a very sensitive virus, so it does work. Okay. It does get killed very easily once we get there, as long as it doesn't get in our lungs.
All right. We are going to move on to topic 3, which is questions from our transfused patients. First question, everybody's question, is the blood supply safe?
So as far as we know, it is safe. Individuals are not at risk of COVID-19 either through the blood donation process or through the blood transfusion process. Respiratory viruses are generally not known to be transmitted by transfusion. So the FDA continues to report, and I just checked on this yesterday, that there's no reported or suspected cases of transfusion-associated COVID-19. So that's very good to know. And that was true for the MERS and the SARS and the other viruses that we had that way. And they have implemented travel deferrals for some just in their blood donation as well. So that'll protect it as well. But we don't expect it to be transfusion associated at all.
Yay.
Yeah.
Given the current blood shortage, should we still transfuse at our normal hemoglobin level, or should we try to go longer in between transfusions?
I would do whatever you normally do. Use your usual transfusion schedule unless there's something specific to your local blood bank. If they report a shortage, right now we're okay. People are still coming in, and we don't want you to get sicker because you're too anemic. So transfuse yourself to what you normally do.
Okay. Do you think the blood supply will dwindle to the point where we will have problems getting transfusions?
I hope not. We're not seeing that right now, even in New York, where things are obviously pretty bad. There's still wonderful people out there that continue to donate. COVID seems to be, and obviously COVID's not affecting all places at the same time. So even if we're short here, we can get blood from Florida and Kentucky and other places that don't have a problem. So I think that should be okay.
I'm going to answer a question that came in only because I just made a call. One of the questions is there really a blood shortage? And Dr. Vlachos, you can certainly talk about it too. I actually called the American Red Cross to ask them about blood shortages. And of course, a lot of it is going to be local, depending on where you are. Some of them are community-based, some of them have Red Crosses. But what they explained to me was that there really wasn't, quote unquote, a shortage. It was that so many of the donations had to be canceled because so many of the Red Cross donations are done at fire stations and they're done at schools and they're done at places of work that have closed down. They had a problem making the collections. So they're encouraging people to make appointments and to go, not necessarily that there was a shortage that people were afraid to give. It was their opportunity to give where those were really taken away from them. So I have a friend who went to make when we went to donate blood, we couldn't get a appointment for almost 3 weeks from now because the spots are taken. So I think that's one thing to consider is Dr. Vlachos is right. There's a lot of great people who are willing to give, and it's just a matter of encouraging people to go and getting them to go. So in the Red Cross's opinion, there was no shortage. It was a trouble of collecting it and supplying it that way. So I don't know if you have anything to add to that.
No, that's perfect.
Okay. We have come across doctors who want to limit the need for blood transfusion and suggest the use of steroids. What would you advise as having the lowest risk for DBA patients at this time?
I would continue whatever regimen the patient is on right now. I don't think it's a good time to try steroid trials right now. I think if you're on transfusions, stay on transfusions. If you're on steroids, just stay on steroids and just keep it at where you're at. I do want to just interject very quickly. I know that there's been some articles going around about blood transfusions and potentially using blood transfusions to treat the COVID infection. There's some hypotheses about the fact that there's a higher ferritin in these patients and this ground glass appearance of the lungs, and maybe this is because the iron is coming out. And there was a couple articles that I know the families have shared. First of all, those are hypotheses. There's no data in those articles at all. Those are somebody's theorizing about why the ferritin is high. Could this be about something to do with iron? How this ground glass appearance happens? Honestly, we see high ferritin in patients that are very sick. We see ground glass appearance when patients have acute respiratory symptoms from anything, not just from COVID. So that's a very common radiologic picture. So that's not something that's unique to this, except that more people tend to get the pneumonias with this as opposed to the regular flu or other viruses. So we're transfusing patients as they routinely are needed. We're transfusing patients with COVID, whether they have DBA or not, as they need them. If they become anemic, they get transfused. We're not seeing a difference in terms of that we haven't studied that yet. So that's something that I know the articles have been going around, but I'm not really sure what to make of them because they're very theoretical. There's absolutely no data yet at all for that. Also, there was, I know, a study about Desferal being used as a treatment for COVID in China. People are trying to use everything they can. And again, high ferritin, so they're thinking of Desferal or desferoxamine. We know that too much iron or too little iron is not good. And obviously iron control is very tight in humans. For everyone that's come to camp and heard Dr. Wolf talk, we know that iron has to be kept in that prison. And if it comes out, we have trouble. So iron balance is key for all our transfused patients and for everyone. And too much iron definitely is detrimental to the organs. So I'm not really sure exactly what they're thinking with this Desferal trial that they're doing in China. But again, these are all kind of people, everybody, trying to do things from different aspects of the disease. We don't have anything. We don't really know what that means. So what you're reading online, please, please, please.
Would you mind just building upon that? I know you said that it's not a good idea to start steroids right now, but someone asked if they're currently on steroids, would increasing their dose be safe at this point?
If they need to increase their dose just because their hemoglobin is lower, then by all means, if that's what they need, if they've grown and need to go up on their dose a little bit or whatever, it needs to tweak the dose like we always do, that's absolutely fine. If they are more anemic for whatever reason and need to go up on their dose, that's absolutely fine. I would not change our regular management of DBA at this time. We don't have any indication to say that we shouldn't do that right now at all.
Okay.
Should chelation be stopped with any fever? Is it the same recommendation if you're on either Desferal or the XJ/JADENU?
So we stop chelation if the patient has high liver functions or significant increases in their kidney function. We don't stop it just for fever. So if the patient comes in with fever and we check their comprehensive metabolic panel, their chemistries, and we see that their LFTs and their creatinine are elevated, then automatically we stop, whether it's Desferal or Deferricerox, which is in XJ/JADENU, we do stop those. But that's routine, again, with anyone that comes in with fever, not just for COVID. Then yes.
Okay. I read that it's a good idea to start taking zinc and vitamin C to help protect against COVID-19. Are these okay to take for the short term while chelating? If they wouldn't hurt, why not try?
Again, zinc comes from a while ago. There was a whole big article about when there was SARS, that back in 2010, that it was supposedly inhibiting the replication of the virus, of SARS virus, the coronavirus. Zinc definitely has been, and it's been reported to possibly reduce the duration of the common cold. So a lot of people take zinc when they get sick. However, we don't know anything about zinc and COVID-19. And definitely too much zinc can be toxic. So don't overdo, and be careful. If you're not taking it already and your body's not used to this, don't do things now in the middle of all this, because then we won't know what we're doing. And if you get sick, we don't want something else to be that you're in the hospital for zinc overload instead of something else happening. So please be very careful. Vitamin C obviously is always associated. If you have, it is good for infections, and vitamin C deficiency is associated with increased susceptibility to infections and poor wound healing and increased risk of pneumonias, et cetera. But again, we don't have any evidence that high doses of vitamin C can prevent or treat COVID. For patients that are being chelated, vitamin C is something that has to be taken extremely, extremely, extremely carefully. There's only a couple studies out there about vitamin C. We know that it makes the chelation work better, but it has to be given at low doses when the person is active ongoing chelation. So if you're on 24/7 of Desferal, that's something. If you're getting Desferal 4 times a week, that's not enough, because if you're taking vitamin C during those other days when you're off, it can cause detriment and move the iron around to other places, especially the heart. So vitamin C with chelation is always very tricky, and we don't usually do that unless someone's severely iron overloaded and being monitored extremely closely.
Okay. In critical COVID-19 cases, ferritin is apparently, we kind of touched on this, ferritin is apparently elevated. If a DBA patient becomes infected, is there anything admitting doctors need to know about how DBA patients might present regarding iron and ferritin levels in the body and how they are measured?
So if you're iron overloaded and you know your ferritin, if it's 1,000, we have patients that walk in the door with COVID that have never been transfused in their lives, and their ferritin is 8,000, 5,000, 10,000. So obviously, if your ferritin's already 1,000, it's going to be higher. But we don't know what that means, and we don't, there's just, your doctors would know your baseline potentially if you're a transfused patient. I will put a plug in here though for the DBAR. We want to collect information about anyone infected with COVID, or especially if they have confirmed COVID, both for their list of symptoms, their outcomes, what they've done, et cetera. So we'll talk about it more at the end, but we do want to get that data at the DBAR.
I do have one more question just in relation to transfusions. They just wanted some information about not getting their usual amount of blood if for some reason it's not available or whatever the reason may be. They were just looking for what complications can kind of come about from that.
I mean, the typical that you feel anemic, that you feel fatigued, that if you don't get your full unit or your full amount of blood that you know, if you get 2 units and you only get 1, you're going to need another unit, another transfusion in 2 weeks instead of 4. I mean, so the typical complications that we always would have if you don't get what your normal transfusion would be. anemia, feeling fatigue, not feeling up to yourself, and needing a transfusion sooner.
Okay.
Okay, we're going to move on for questions for steroid-dependent patients. Should we refrain from starting steroid trials during this time, maybe within the next 6 months? I have heard that steroids can make the immune system weaker.
So I am recommending that we refrain from starting high-dose steroids at this time, especially if you're in a COVID risk area like New York, and we have done that for sure. Normally, what I do is at around a year of age, the patient receives the routine live viruses, measles, mumps, rubella. About a month later, the patient usually gets a bone marrow aspirate and biopsy if they haven't had that earlier in their course for diagnosis, and then we start the steroid trial. At this point, in our hospital, we are not allowed to do routine bone marrows, so that bone marrow wouldn't be able to be done. If we start high-dose steroids and the patients can, every time they have a fever, they have to come in for fever. I don't want to have to do that in the middle of all this, and definitely have to come in more for monitoring if they're on steroids. We usually have them come in weekly so we can check their blood pressures, et cetera, when they're on the high dose the first 4 weeks. So therefore, for us, we are not recommending that at this time. Getting a few more transfusions, another 2-3 more transfusions compared to your first year's worth is not dangerous, and that's much safer than being in the ER multiple times to manage your steroids or the office. So we're not doing that now.
Should we be concerned about prednisone stock?
There's no reported shortage at this time that I could find. There wouldn't be.
This is kind of the question that we talked about, but I'm going to throw it in just because it's here. I read giving steroids can make COVID-19 worse. If my child gets it, should we not do a steroid stress dose protocol like we normally do with any other illness?
Right. So like I said, we are using steroids to treat the inflammation in some patients with COVID. And obviously adrenal insufficiency has to be treated. So if you've been on steroids all your life and you're 15 years old and you have a fever, and you have a high fever, you really need to get your steroid pulse. There's no your stress dose, and obviously not getting it could be extremely detrimental. So yes, please give your steroid stress.
Okay, topic 5. We're going to move on to transplant patients and patients in remission. In your opinion, like other viruses, do you think this virus can knock a person out of remission or make a patient's DBA worse?
We don't know. There's no way to know. We know that patients that come in that are out of their remission tend to have a history of having a virus or something 2, 3, 4 weeks ago, 2 months ago. So we don't know if this will be the same.
How concerned should we be about the seasonal flu knocking someone out of remission?
Same thing. We don't know. I mean, it can. Some people get through it fine and some people come out of remission.
Oh, there's so many definitive answers for DBA, isn't there?
Sorry.
No, it's true. I mean, you don't know because maybe it would one year and not the other year with the same person.
Different flu. Well, different flu strain.
Do you have any knowledge or data from your colleagues abroad or in transplant centers of post-marrow transplant patients who have contracted coronavirus, and what was the outcome?
We really don't have any data worldwide. In our local experience, we have had patients not with DBA, but other transplant patients that have went home after transplant, came back with COVID infection, and they're back home fine and doing fine. So we really don't know, but obviously we also have patients in transplant that have it and are not doing well at all. So it's something that we don't, I mean, just like we don't know why certain patients get so sick at age 40 as opposed to age 75, or why some patients get sicker at age 25 instead of 45, we don't know. And that's something that we're going to try to figure out in terms of COVID in general. During this pandemic, however, because DBA transplants are considered elective unless you have leukemia or MDS, we're not doing any DBA transplants during this time. We're not starting people on transplant, not just for DBA, but all patients like sickle cell disease, patients that are more elective that we can wait a little bit. We're waiting for this pandemic to be over before we do bone marrow transplants again.
Okay. I'm going to throw this one in on you just because I know we only have a few patients, but it's been asked a couple of times. Any words of advice for people who have had splenectomies?
Splenectomies, obviously the fever is it's increased because of the bacterial infection, because of the risk with bacterial infections. So again, if you have a splenectomy, you have to go for every fever. And just because one is not positive, I mean, they have to be treated for bacterial infections always when they have, if they have a splenectomy. So they have to be even more cautious during this time because they could assume it's COVID and then not be COVID or et cetera and be a bacterial infection. So we don't know if they're at any increased risk for COVID though. There's no data for that.
Okay. Topic 6, questions regarding COVID treatments and vaccines. If a DBA patient gets COVID-19, can we be given some of the possible treatment options mentioned in the media, such as hydroxychloroquine, Zithromax, antibodies from plasma, or anything else? Are there any contradictions to these treatments specific to DBA or our DBA treatments?
Okay.
Can I actually interrupt for 1 second? I'm sorry. I can even go back like after you answer this question if that's easier. I just wanted to find the question, but we had one more question about post-transplant patients. Do you want me to like proceed with that, or do you want me to?
Sure. Go ahead.
Okay. So they asked about a patient specifically, but she, regardless, the patient who is post-transplant had previously had both pneumonia and like a secondary lung issue. With COVID being a respiratory issue, even if they may not be DBA high risk any longer, is there, I don't want to say like fear, but is there precautions that they should take or a higher risk pool that they're being put in because they've had a history of lung trouble?
Right. Anyone with any pre-existing lung disease, asthma, et cetera, is potentially a higher risk because this specifically targets the lung tissue. So yes, if you have any decreased reserve there already, it's potentially a problem.
Okay, thank you.
So with regards to treatment, I'll spend a little bit of time just so people can understand this. So again, your physician should make your treatment choices based on actual, because right now we don't have much data. So it's very difficult because a lot of the data are sparse. However, your physician should make it knowing your individual risk profile. And again, what's available at that center, what trials are available at that center. So recommendations that I'll talk about right now are changing all the time. So as more and more data become available, we'll know more things. So the typical medications when someone walks in the door with a COVID infection, with or without DBA, just in general, have been chloroquine and hydroxychloroquine, and it was with and without Zithromax. Most recently, at our institution and many institutions have stopped using Zithromax as the newer data don't really have much increase in the effectiveness of the combination. However, what we're seeing a lot of is cardiac arrhythmias with the drug combination. So we've pretty much stopped giving Zithromax as people walk in the door. They used to get both. Now we just give hydroxychloroquine. With all the patients, and we've probably had, like I said, 300 or 400 now, the data. We've had over 500, but the data that we're starting to accumulate on the adult side especially, they're able to start seeing that Zithro doesn't really help one way or the other. The effectiveness doesn't seem to be increased, but we're seeing cardiac arrhythmias. And we've actually had about 14 in our practice, and we've already had 3 that have cardiac arrhythms. And this is in 13-year-olds and 15-year-olds. So that should have had normal hearts, we thought. So we stopped the combination, and we're giving hydroxychloroquine alone, either chloroquine or hydroxychloroquine. However, when we use it, because of the risks of the cardiac arrhythmias, all those patients are patients that are admitted. So we're working with cardiology. They're on telemetry units, which means that we get to watch their heart rates. They're on, if they're not on that type of unit, they're getting daily EKGs. So everyone on hydroxychloroquine, which is the one that we're using mostly at our hospital, also called Plaquenil, is being monitored. We're not giving it for people to go home with. They come in for when they're inpatient to get that drug. And obviously in our patients that have possible cardiac arrhythmias or cardiac iron overload, that would be something that would have to be on some type of continuous monitoring. You do not take this at home, and you don't take Zithro at home without being monitored appropriately. We're also using some other antiviral drugs. One of the bigger ones is remdesivir. It was developed for the patients with Ebola virus. We don't know its efficacy specifically in COVID patients, but it's one that's out there that people are using. The adults can get it on a clinical trial if their institution has the clinical trial open. For children, we are getting it by compassionate release, and we've been able to do that now for probably about 10 or 12 patients at our institution, including some hem-onc patients. So that's something that we'll hopefully be able to tell people about quickly, since we're kind of a big center and have a lot of patients on these drugs. For theoretical reasons, we're using some known anti-inflammatory or anti-cytokine agents, something called tocilizumab or anakinra. Those are specific interleukin inhibitors to try to decrease that inflammation that we see with COVID-19. We're not using them together. We use them most of the time separately. And we're starting them pretty early if patients, just to decrease that inflammation, to see if they can knock down the fever a little bit, knock down the inflammatory response. Again, none of these drugs, that, except for the hydroxychloroquine and the azithromycin, that potentially have cardiac arrhythmia problems. And if you are a patient with iron overload, and especially cardiac iron overload, that would be something that you have to be very, very careful about. The other meds that I talked about don't seem to have any, there's no specific data about DBA, but there's also, I don't see any contraindications for giving it to a DBA patient. Again, that have to be administered by your physician in consultation, usually with endocrinology, cardiology, infectious disease, et cetera. We have everyone on every patient at the hospital. Everybody comes. We make these humongous rounds that everybody's all over the place or on the phone. I do want to touch also on the convalescent serum therapy, the plasma therapy, because that's also will be coming. So what we do know is that people that recover from an infection develop antibodies to that virus, and that's in the bloodstream, and it sits in the plasma. That's where antibodies are. So there is evidence that these antibodies can then neutralize the virus. So if we could take the plasma from one person and give it to another person, those antibodies to COVID would then fight that other person. So this has already been started we've used this for measles back in the 1930s, for polio years before that. So this is something that's been done multiple times. This is not new, this plasma therapy. So what we're trying to do is that we extract the patients actually would donate plasma like they donate blood. And one person's amount of plasma that they would get would probably be enough for 2 to 4 people, depending on how much they got for the person. So one person could help 2 to 4 people. Each donor would be able to do that. And right now we are looking into that at many institutions. Johns Hopkins was the one that jumped on the wagon first. They have now gotten about 30 institutions throughout the country to work on this. They've gotten FDA approval to move forward fast. And right now, I think they are scheduled to open May 1st on their clinical trial. I know we're on it as well. I don't know when we're scheduled to open. We've gotten an email about it, but it's, I think, looking for people to donate, but they haven't obviously used it yet. Initially, I think it'll be used to help people that are in very dire straits. It will eventually also be used for people that are moderately sick to try to keep them out of the hospital and not get them on ventilators. And it may even be used for healthcare workers and people that are right at the front line, essential workers, to give them passive immunity. But that's later. I mean, we're not sure. There'll be like kind of 3 arms to it, I think. So that's happening, we hope, within the next couple of weeks. So it's coming. People are moving. The FDA, honestly, has been moving remarkably fast, which Dawn and I know FDA is very slow. Government tends to move slowly, but everybody has moved so fast for this. It's a pretty remarkable response.
Oh, very cool. Is there ever a chance, this is just me talking to you and pretending that there aren't all these other hundreds of people with us, is there ever a chance that they could use the plasma kind of as a precaution, like if you thought you were exposed, and down the road once everything stops, but if you thought you were exposed to somebody, could you use it kind of?
Potentially, just like you would IVIG, and it would just be ones that were specifically for COVID. So potentially, especially if you have an underlying issue, to be able to give it. The question is, we don't know how long that will last. If it is passive immunity, will it just last for a month? Will it last for a while? We have no idea, because it's obviously not your antibodies, it's someone else that came to you. But we just want to get these people out of dire straits.
And my understanding is we're thinking that if somebody does have it, they will have, but because this is so new, we don't know if it's going to be a lifetime immunity or if.
Right. So that's the next step, the vaccines that are coming. So the vaccine will be a kill vaccine. We expect it to be safe for everybody. It's not going to be a live vaccine. So therefore, just like you get the flu shot, you would get this. So we expect it to be safe for patients on steroids, transfused, et cetera. Again, we don't know how would DBA be any different, or the patients that are immune suppressed be any different. We don't know. We'd have to monitor that. We hope that we'd be able to look at that as well when we get all this data. But that would be something that we'd look at and see. Right now, what's really, I guess if there's a silver lining, is that the virus isn't mutated. And what we saw in China and what we see in Europe and what we see here is the same. It's the same genetics of this virus. So if that's the case, maybe this would last for a year, 2 years, or 3 years because it doesn't seem to mutate. If it starts to mutate, then it becomes like the flu where you have to get the shot every year to try to get past that period. But so I think that's where we're at right now with the most recent medications that I know of and that we're using. And again, I get a report every single day because I was on service for 2 weeks. We get them every single day about what the new thing is, what's happening here. It's constant. It's constant. And people are working 24/7 to figure this all out.
And you are too. So thank you.
Yeah, not quite.
We answered this question, but just because I'm going to answer it. So you could just say yes, yes, no, because we know the answers. But do you know if the vaccines that are being worked on are live or dead? If the vaccine becomes available in the future, will DBA patients be able to receive it and patients on steroids?
Right. So kill vaccine, everybody should be able to get it.
Good. Researchers are looking into the BCG vaccine, an old TB vaccine, as a possible COVID-19 prophylactic that may lend a layer of protection. What should DBA patients know about that possibility? Should they get it if they can?
So BCG is not available here. It is a live vaccine that has been used in areas where tuberculosis is still a very prominent disease, many third world countries, et cetera. So babies get that right away, but it's a live vaccine. So it boosts the immune system to make the antibodies against tuberculosis, which then protects them and hopefully fights. There is some indication that it may also be able to fight other respiratory infections, but we're not quite sure about that. They're doing some trials now to look at that and to try to immunize patients in other physicians in other countries to see if that would help them be more immune against it. But it looks like there's going to be one. I looked it up yesterday into Mass General is looking to start something like that. But obviously we would not be doing that. And patients on steroids, it's a live vaccine. So that would be very specific. It wouldn't be something that would be for the general population, I don't think. At least not at this time. And there's no proof yet. So.
In a few months, when the imminent threat of this virus has hopefully died down, many DBA patients will be at a higher risk than the general population. Should we consider continuing to work from home or homeschooling until proven treatments and/or a vaccine are available?
So again, we don't know, we don't have any evidence that patients with DBA alone are at higher risk of getting COVID or having a worse outcome. This all still remains to be figured out as time comes. So the severity of the disease, the current steroid dose, the iron burden, all have to be assessed as an individual thing. Hopefully people will only be permitted to return to work when it's really safe to do so, and it'll depend on the population at large and how well we can monitor the amount of virus in the population, how much infection there's out there, and therefore what can be safe when, how many people are already infected. As from working from home or returning to school, that's going to be something that the CDC and everybody's state departments of health will follow those guidelines. And then obviously, if there's something specific to you or your child, then that would be something, again, that you would speak to the to your physician about. Right now, at least in New York, I don't think that the schools are going to reopen for the rest of the year, truthfully. I mean, they may. People right now, we're up to April 30th. We keep moving at 2 weeks, and then at 2 weeks, they tell us again. All our tests and stuff have been canceled. The kids are doing everything online. I think it's going to be a hard time to reopen things for now.
And this kind of was a question that went with it. When will it be safe for a steroid-dependent DBA child to return to school?
When it's safe for everybody, then it should be safe, but I don't think it'll be soon.
I think one thing.
Again, I'm in New York, so I'm speaking from New York. I can't speak again to other places. So that's, we're really in the middle. We have an epicenter bigger than everything that happened in the whole world. So I'm speaking from a very different vantage point than everybody else. So.
And that's what I think we have to keep in mind, is that everything's going to be different at a different time for everybody. And I think that it's going to be by location. I also think it's going to be a matter of time. Just think back 2 weeks or a month ago. So 2 weeks from a month from now is going to be a very different situation than where we were. It just is evolving, and it's going to be where the infection rates are at, what the hospitalizations look like. It's also going to be just in general, what we know about it, what is becoming more available, what's not more available. So I think it's really hard to take everything that we're saying now and think that this is going to be what it's going to be like a month from now or 2 months from now, because everything is changing so rapidly in all areas of this. So I think we have to keep that in mind.
Right. And I think that's a very scary thing. I mean, even if, especially for patients and parents of patients with DBA, that you have your set routine, you're doing stuff, and then something gets thrown in, everybody's lives are all over the place, and you're scared even more because you don't know what tomorrow will bring. And we all don't know that. I mean, we really don't with regard to this. So I think we're hopefully plateauing here. We've been now kind of at the same number of inpatients, whether even if we've had patients come in, new patients come in, like 60 the other day, we had 74 go home in 24 hours. And yesterday. So that was like one of our biggest days of people going home. So, I mean, we've had hundreds and hundreds, I think 750 or 850 that have gone home. So we're really seeing now, because some people are on ventilators for 2 and 3 weeks, but now we're at that point where a lot of them are going home. So it's really exciting to see. They ring bells all over the hospital when people go home, because it's really, and people will run downstairs and clap for people that are walking out. I mean, it's really pretty amazing. So but we're hearing them. We were hearing codes all the time. Now we're hearing these bells all the time. So it's actually, I think it's finally like making it, because we kept hearing all these codes. It's very hard to hear that all the time, literally 2, 3 an hour, or sometimes like 3 in 5 minutes. But now we're hearing the chimes all the time of people going home. So we're hearing that really a lot. So that it's kind of balancing it off I think that's more for us as more than it is for the patient, that we need to hear that because we hear these other things that are really very hard for us to deal with all the time. Oh no, So we're hearing that all the time, and it's really great for people to go home. We're seeing more and more stories about that. So I think we're flattening out. I'm hoping.
That's awesome. I'm gonna throw in 2 more questions, and then we're gonna go, because I know we're over. But what about like routine stuff? If people have routine visits or their ferry scans, yearly ferry scans, where are we standing with that? Is that okay to wait?
Yeah, we can't get it. I mean, the MRIs are only doing MRIs for these patients and patients that need to be there. So if you break your leg, you need to have a scan. I mean, but if, so you need to be there. But otherwise, we're not doing anything routine, which we shouldn't. Why should you go into an MRI and see 5 people when you're like, you really don't want to be there? Nobody should be there. Go in July, hopefully.
The other question that came in is, everybody's reading a lot about from China, the different hemoglobin or the different blood types, if you're this blood type or that blood type. Anything to add to what we can actually read that's out there?
I don't know what to say. I mean, we've seen that, I know A positives, instead of saying A positive is worse, I'm A positive. So I don't know. I don't want to read it. Nobody knows really. I mean, I think, it's one of the most common, and it depends on where it's most common in each area. So it's hard to know really how to put one piece when there's so many pieces to someone that's sick. So it's very difficult to say. Definitely those things that we talked about in terms of obesity, in terms of cardiac and respiratory issues, in terms of diabetes, hypertension, those things definitely you can see those. But all that data we won't know till much, much later when everybody can breathe and really look at the data. It's pouring in right now, and we just can't keep up. I mean, so we need to really analyze it in a more structured way, which will come, but I don't know that's, like, we're not running out of A blood because that's the ones that are sick the most. I mean, we don't, so I can't really know what to make of that.
Okay. So this one I'm going to throw to you, and I'm going to let you do what you want to do. Lastly, is there anything you think that is important for us to know that wasn't specifically asked?
Biggest things are, please speak to your own doctor or your child's doctor to make sure that they review your own individual risk profile so you kind of feel comfortable as to where you're at. Don't take any medications on your own to prevent or treat this. Please, please, please do this in combination with doctors. There's no medications that are being used prophylactically at this time. So we're still learning what the best regimen is. So please, again, be careful. Since I started last Monday on service to yesterday, we were using azithro. We're not using azithro. We were putting them on Plaquenil twice a day. Now we're doing it once. I mean, everything changes every day, and that's in our small little place, compared to the world. So everything has to be titrated. Please don't do things on your own. That's scary. The DBA registry obviously was in the midst, right when this all started, of a huge update. that we were sending everybody. Everybody should have received by mail an update form. Please take the time to fill this out and return it to us. Even though our research center is closed, the Feinstein is closed right now. It's been closed since it's almost 4 weeks now. We're all working from home. Our phones are all sent to our cell phones. So Maria and Miriam and Eva, you'll get their voices when you call our regular lines. They're being diverted to their homes. They have their stuff set up. We have meetings, and we've been using techniques to every once in a while, not just talk to ourselves, but to see ourselves. Every week, the girls are coming in to pick up the mail. The ladies are coming in, excuse me. I don't want to, I'm the old one. So to get the mail, they love to see the updates. Every time we get an update, like, hey, we got 7 today, we got 10 today. So it's exciting to still get that. They have special permission to go in once a week. They have to go in separately. They can't go in at the same time. They get things. So they're still working on the DBAR. We're still active. We have 2 clinical trials that are ongoing, the sotatercept and the trifluoroperazine. Of course, they're both suspended to accrual because right now we're just doing COVID trials and our cancer trials that have to go. But anything that's extra has been suspended the whole institution wide. But as soon as this is over, they'll be back in force. If you're interested, please call us, email us. We'll send you the consents. You can start looking them over, looking at them. While I've been working from home a little bit, we've been doing getting the leucine study ready to be published. So that's good. Again, if you have COVID, or know of, or you think you might have had it, any data that you have, please call us, let us know. We will get you a questionnaire. We'll put it on our website so that way you guys can fill it out there. I'll get that written maybe today or tomorrow and put it on the website. I thank you all for thinking of doing this, Dawn and Kyle and Melissa, and for everyone for asking questions. I really appreciate the opportunity to speak to you and to answer these questions. Happy holidays to everybody that celebrates. We have Easter, Ramadan, Passover, etc. Thank you, and please, 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 last but not least, be safe and stay healthy, everybody.
Dr. Vlachos, we appreciate you so much. I every day of the year we appreciate you, but taking your time out, especially being in New York City, we cannot thank you enough for doing this. Our families, our Facebook's blowing up with thank you, thank you, thank yous, and they're all meant to you. So we really, really appreciate everything that you always do for us.
I appreciate you guys. This is, and even our little glitches with our computers. We got through it.
We got through it.
Yeah, we got through. So
you guys missed the 15-minute try to set up here when we had birthday parties and Elmo's going on, but all's good outside.
Outside. I sent my husband out to send everybody away from the front doors, and God knows where they were. I don't know whose house they were going to, but they were all wearing masks, so that was good. They all had masks on.
Even Elmo.
Even Elmo had a mask on. I sent the picture to Dawn. It was good. But
we really do. We appreciate you, Dr. Vlachos, Melissa, and Kyle. I appreciate you, and our families. Honestly, I thank you guys so much. You're the ones that keep the foundation going. You help us get the information to the DBAR. We need your data in there. I know we have had three patients who have called me with possibly having some COVID. Please keep those calls coming. I can divert you to Eva and to Dr. Vlachos. I know Dr. Vlachos is super busy, as you can imagine, but that data is important. So please keep reaching out. You all have my phone number. You all have my email address. You can all get a hold of me on Facebook. Please keep doing that. We need you guys. We need you in many ways. So
data is the only way that we beat everything. Research and data. You know that. Look what happened now. I'm hoping that the governments all still remember this, that we need research when when this is all over, for everything, not just for COVID.
And as an aside, of course, our International Collaboration Conference, which is the big scientific symposium, which Dr. Vlachos can tell you how important it is, where we have doctors and researchers from around the world come together. That was postponed because of this. But, you know, we've all been keeping in touch, and some of our main researchers come from the parts of Italy that were really hit, and they've been keeping in touch with us. So we're all in this together. We will make it through as a DBA community. I am here. Please call me. If there's anything at all that I can do, I'm here. So thank you, everyone. Dr. Vlachos, thank you. Thank you, Kyla and Melissa. Thank you. Thank you. Everybody who's been texting me, thank you. Thank you. We appreciate everybody.
Thanks, everybody.
And we almost made it. We planned on an hour and 18 minutes. That's good for us, Adrianna.
I know. Sorry, you know how fast I talk. I tried, but
you did.
I had a lot of questions. They were great questions, but that's a lot of questions.
It was.
Thank you, everybody.
All
Bye-bye.
right, thanks, everybody. Bye-bye.
Bye-bye.